Hi, my name's Paul Sadler. I'm giving my second talk of this meeting, and it's going to be presenting three bits of unpublished research from our clinic in Perth, Western Australia. I've got no conflicts of interest. But first, there was just a couple of thoughts that have been generated by attending this meeting, which has been excellent. But the first thing was that when we see patients in clinic, it's about risk reduction, not risk absolution. So when you see patients, or when a patient has a life-threatening perioperative reaction, if you were to give them another anaesthetic, presumably they would have a high risk of having a subsequent reaction. And so the reason why we see them in clinic is to reduce their risk. And if you do see a patient and you skin test them and all of their skin tests are negative, then that moves the patient from a high-risk group into a lower-risk group, because we know that patients that are skin test negative to all of the allergens, the vast majority have a safe anaesthetic subsequently. Now, if we then go further and do things like specific IgE tests, provocation tests, BAT tests, however you want to further investigate the patient, that's moving the patient into groups that are of lower and lower risk, because each time we have a negative test, it becomes less likely that this was truly an immune-mediated or an IgE-mediated or a specific hypersensitivity reaction, and rather it was more a general reaction of multisystem from other causes, and usually that would mean that their subsequent anaesthesia will be well tolerated. So that's important to remember. We're not saying to someone after they've been to the clinic that they necessarily have to have all the answers. We're just reducing their risk. I mean, that people have different approaches, and in our group in Perth, we all have different approaches, and some would have more of the approach that what we're doing is providing a service, in that we're providing a testing service. So our job might just be to do the skin tests. Patient comes, we do the skin test says that all of the allergens were negative, and then we just say, well, that's the test. It goes back to the referring clinician to make a decision about what to do for the subsequent anaesthetic, or indeed to decide if the patient needs to be investigated further, or to interpret what those skin tests mean. I prefer to have the approach where I want to know what happened to the patient at the time of the reaction, and in fact often if I do have a patient with negative skin tests, I'll ask the clinician to give the same agents, if appropriate, in subsequent anaesthetics, because you kind of want to delabel the patient for good, and the best way to delabel them is to use that drug in a subsequent anaesthetic. So then the other thing is that I sometimes remind these patients that they're already a different group because they've survived anaphylaxis. And if you've survived it once, maybe you'll survive it twice. If we do a bad job and they end up having another reaction, which hopefully they won't, you might say that, well, look, if you re-expose them to the same allergen, the reaction could be much worse the second time, and that's true. But also remember that the next time these patients have anaesthetics, it'll be a much different anaesthetic as well, in that they won't be having an anaesthetic in a peripheral hospital with a 22 gauge cannula in. They'll be hopefully in a tertiary centre with absolute expert experienced clinicians looking after them, with an ICU on site, and they'll probably have higher levels of monitoring, and more care will be taken, and the clinicians will have a plan for if anaphylaxis happens. So the subsequent anaesthetic will definitely be safer. So the other thing is, we've had in our clinic, we've been sort of mentoring a new specialist for the last few years, who's obviously now exceeded our capabilities. But there's some things that we would teach a new clinician that hasn't been mentioned at this clinic yet. And the first thing is that drawing up drugs for skin testing, like everything, mistakes can be made. And it's quite a complicated task and an arduous task. We're drawing up lots of drugs. We're doing multiple dilutions. And it's very easy to lose track of how many dilutions you've done, or indeed which drug you're drawing up. And it's not impossible to make mistakes. And so often if the skin testing just isn't making sense, or if we do get negative tests in someone who we expect to find a positive because they've had a serious reaction or it just looks like an IgE-mediated anaphylaxis, you need to consider, well, look, maybe we made a mistake in drawing up the drugs, and we will often redraw the drugs up, maybe just the most likely culprit, or all of the drugs we might redraw up if we really are uncertain. And we also might retest. So if we're testing on the arm, we might retest on the other arm with new dilutions. Or we might ask the patient to come back on another day. And in fact, sometimes we just, we will say to the patient, look, this just isn't working today. And we will refer them to come back to see a different colleague on another day, and for them to start from scratch, just to look at the case with fresh eyes from the beginning for, missed allergens and hidden allergens and all that sort of thing as well. And the other thing is that I think one thing I've gained an appreciation of talking to some of the people here, like Didier and Vito, about the in vitro testing. It's one thing to say that you understand something by reading books or by reading papers. It's there's a different level of understanding if you are actually doing the thing. So, and the same goes for skin testing. If you are actually doing skin testing, you have a heightened appreciation of. It's not only about wheel size and bleb size and injection volumes and stuff. There's more to it than that. And so, patients vary. Some patients will be on antidepressants that have significant antihistamine properties, and it's not possible always to stop their antidepressants, or it's not advisable to stop their antidepressants, we don't think. And so, by doing the skin testing yourself, at least some of the time, you gain an appreciation of the different appearances of positive and negative tests under different circumstances. The next thought was that it would be really useful to have on the ISPAR website somewhere to post questions that experts or colleagues from other regions could answer, because as we've seen in this meeting, there's quite a difference in practice around the world. And I think for some of the patients that we see that we're having trouble making a diagnosis on, the approaches that we've heard about in other countries might be more appropriate. And so posting, anonymously posting such cases and also asking for the experience of people around the world in similar situations would be fantastically useful. And sometimes also with research, it would be useful to publish thoughts or ask questions, because obviously sometimes other people have had the ideas before and that they've explored them before and they've come to a dead end, and being told that something goes to a dead end is as useful as finding the actual grail that you're looking for, because knowing that it's a dead end will let you look somewhere else. Anyway, off to the next bit of research. Phil presented this consensus clinical scoring scheme on Tuesday, and it's a perioperative. It's a perioperative scoring scheme to predict perioperative hypersensitivity, which was essentially immune versus non-immune initially, and it was, I think, originally developed to be used to evaluate the accuracy of current and proposed diagnostic tests. So we wanted to see if it would be useful to use clinically, and so before you can use something clinically, you need to validate it. And so what we did is, and Phil's gone through the particular components of the score and the interpretation scale, there was an amazing amount of work that he put in with the rest of the group, but particularly Phil in assimilating the responses and developing the score. And how well it works in the scenario I'm about to present is just a testament to how clever he was doing it. But anyway, the way we validated it was we redesigned the data collection process and the whole flow of our clinic in order to validate this test. So Peter Platt who takes all the referrals and would call the referring clinician to make sure we get all of the anaesthetic records and data and a proper account of of the suspected perioperative hypersensitivity reaction. He would take all the referrals, and he would complete the clinical score based on the information provided. And of the 351 patients referred to our clinic over 31 months, 321 were eligible, as in it was suspected that it was a perioperative hypersensitivity reaction, multi-system hypersensitivity reaction. And of those 321, we actually subsequently saw 301 of the patients with the full data set. So Peter would score the patient using the scoring scheme, and then in parallel, without us knowing what the answer to that clinical scoring scheme was, the other three clinicians would go through the referral documents and make our own assessment of whether this was almost certain, very likely, or unlikely to be a hypersensitivity reaction, or as in, are we going to find a positive or negative result at the end of all our investigations? This is before we've seen the patients. And then the score of the three experts was combined to give an overall score. So this was the comparison score to the clinical score, because it's one thing to show that the clinical score is better than a coin flip, but it's another thing to show that it's as good as a bunch of supposed experts. So we then, once we've done the clinical score would divide patients into two groups. So a high scoring group and a low scoring group. And so according to Phil's classification, if you have a hypersensitivity clinical score of 15 or greater, you're considered to be very likely or almost certain to have a hypersensitivity reaction. And if it was less 15, it was less so. So that's how we in a sort of binary way classified patients. So if you got a high score, then we found that of the 198 patients, 178 were later determined through skin testing and in vitro tests and provocation testing if needed, to have actually had allergic perioperative hypersensitivity reactions, which is amazing. It's like it's 90% predictive, which is phenomenal for a medical test. I should say that it was very important to define what actually was, what constituted the gold standard reference for allergic perioperative hypersensitivity, and we deem it to be, and the way we practice is that it's essentially IgE-mediated anaphylaxis, which is evidenced by, first of all, a hypersensitivity reaction, which was all of the patients included in this study were considered or suspected of being a perioperative hypersensitivity reaction. And then you had to have two supporting investigations. And that's two supporting investigations out of skin testing, mast cell tryptase, specific IgE, plus or minus a provocation test, which was an IV provocation if required. And so that was our gold standard reference. Now, of the patients that had a low clinical hypersensitivity score, of which there was 103 patients, that was accurate in 79%, 81 patients, which is very useful. So it is correct in classifying patients as not having an IgE-mediated hypersensitivity reaction 79% of the time. If we look at the data points, so these are the, for all comers in this study, these are the features that we saw most commonly. I mean, severe hypotension or hypertension, if you put them together, it was very common. Tachycardia and poor response to the first line vasoconstrictors, which is essentially aramine or pseudoephedrine. Erythema is very common. More than half of the patients had an erythematous rash. And most patients had a reaction within 5 minutes of a potential trigger. And I mean, if you're giving lots of drugs through your anaesthetic, that will be the case. Of the mast cell tryptase grades, there were two grades that were common. And this is the grade 5 means that the acute tryptase was twice baseline and over the upper limit of the manufacturer's upper limit of normal. And grade 1 was essentially a normal acute compared to the baseline tryptase. and that would mean that it doesn't meet the consensus formula for a positive mast cell tryptase. So they were the most two common interpretations of the mast cell tryptase grading. If we look at the accuracy or the predictive value of all of these features on their own, sort of a univariate analysis, well, it's actually just, here we're using the Matthews correlation coefficient, which is just an overall measure of accuracy, which takes into consideration the true positive, true negative, false positive, false negative rates. So in this interpretation, a weak positive gives you a correlation coefficient of 0.2, moderate positive 0.3, and a strong positive 0.4. And it can be positively correlated with the outcome, or it can be negatively correlated with the outcome. So severe hypotension is moderately predictive, or sorry, it is moderately predictive. Tachycardia and a poor response to first-line vasoconstrictors was actually the best predictor. Grade 5 mast cell tryptase, which, as I've already said, is acute, more than double the baseline and more than the manufacturer's upper limit, is also extremely good in predicting that the patient had an IgE-mediated hypersensitivity reaction. And of the negative predictors, having a normal acute tryptase compared to the baseline was extremely helpful in predicting patients that didn't actually have a IgE-mediated hypersensitivity reaction. Of the other negatives, an excessive dose of, which isn't circled at the moment, but an excessive dose of anaesthetic, as deemed by the scorer, was almost a weakly negative result. Surprisingly, an erythematous rash was quite predictive for IgE-mediated hypersensitivity, more so than angioedema, which I was surprised about. So if you had a high score, a score of 15 or greater, that was 189 patients in our study, and that has a positive predictive value of 90% with excellent sensitivity and specificity. A score of less than 8, which is, if you read on Phil's grading scheme, is a score that represents hypersensitivity reaction being unlikely. This was 55 patients and it had a negative predictive value of 80%. But the negative predictive value of a score of less than 15 was also 80%. So the calibration of the test isn't perfect. And if you look at in this picture, we've got the ratio of positives with the potential scores binned on the x-axis, so that if you look at the expert panel score, which is in light grey, it's actually quite well calibrated, so that a high expert panel score, a medium expert panel score, and a low expert panel score is calibrated well to the actual risk of the patient having the positive outcome or a IgE-mediated hypersensitivity reaction. In contrast, the hypersensitivity score, the clinical score, is more of a binary thing. It's very good above, really it's just going to categorize your patients into positive or negative. It's not really going to well specify intermediate risks. But that's fine. I'm not sure that it's that necessary to be well calibrated, but it just shows there's potential to improve the score. So one thing that we did investigate was that of the patients that we had negative skin tests for, 17 of those were referred to the challenge clinic for provocation testing. And the reason why they was because we just didn't feel right that the clinician felt that the severity of the reaction, or it just didn't, we weren't comfortable with not investigating them further. And sometimes this would be because they had a positive mast cell tryptase, but the skin tests were negative, or perhaps the morphine-specific IgE was positive in a patient that had received a muscle relaxant. And so of those 17 patients, 12 of them, when they were referred to the provocation challenge clinic, tested positive. And some of them were to repeat skin testing, or some of them were to IV challenge with the drug. And of these patients, the average hypersensitivity clinical scoring scheme score was 21, so very high, with a range of 12 to 29. So it just it generates the hypothesis, which needs to be validated on further tests, but it generates the hypothesis that this score could be used to indicate when a negative skin test should be further evaluated by provocation tests or repeat skin tests at another time. And maybe it would be appropriate to challenge any score of 12 or greater. Just going to skip over the next few slides because I actually covered most of this in my last talk. The next thing I want to talk about is something new. This is Peter Platt, and that's how he looks at me most of the time when I'm talking to him. But about a decade ago, he said to me, I'm sure we can use cross-sensitivity data, the data we're generating from cross-sensitivity testing and neuromuscular blockers, to tell us something about the relative risk of anaphylaxis to rocuronium versus the other agents. And I wasn't convinced because it depends on the frequency of drug use, and the patients we're seeing are all selected for by being given rocuronium, and so maybe the cross-sensitivity patterns would be completely different if we were using lots of, say, cisatracurium or vecuronium and selecting patients to appear in clinic that way. The cross-sensitivity patterns could be completely different in those patients. But then after about 12 years, I worked it out, and so I'll present to you what we've been thinking. So this is a beautiful cloud. This is the, I think it's the Lesser Magellanic Cloud. And this cloud is a long way away. All of the stars, it's so far away that all of the stars in the cloud are approximately the same distance from Earth. And Henrietta Leavitt is pictured, and she was at the turn of the 20th century. She's working at Harvard Observatory. And she she's a calculator there with a whole team of there happened to be women who were helping work through all the data that the observatory was producing. So she was looking at plates of the Little Magellanic Cloud, the Small Magellanic Cloud, and she observed that there were variable stars or periodic stars that brighten and dim periodically. And what she noticed was that the maximum intensity at the peak of their brightening phase was correlated with the period, so that and it's of course everything in nature is linear on a log scale, but yeah, so the stars with the longest period of these particular stars with the longest period had the maximal luminosity. And so what this meant was that wherever you look in the sky and you see these particular periodic stars, if you know what their period is, you can say how luminous they are. And so that way, obviously a star is bright or dim because of two reasons: because of the distance from Earth and also because of its luminosity. Well, now they could fix the luminosity, and so therefore they could use this to determine their distance, and then later on Hubble used this in part to prove that the universe is expanding. So in the same way, can we use cross-sensitivity? So this patient obviously has got two beautiful wheels with flare to rocuronium and vecuronium. Now, I ask what would happen if this patient was given vecuronium. Presumably they'd have a reaction. And what would happen if they were given rocuronium? Presumably they'd have a reaction to rocuronium as well. And this is the whole basis of cross-sensitivity testing. This is why we do cross-sensitivity testing. And this is, that's the assumption. Now here's two more patients, and I call these patients polyreactors. So if we just think about rocuronium and vecuronium, you can either be an orphan, so you just react to the drug that got you lobbed into clinic. So, if you had anaphylaxis to a bunch of drugs, including rocuronium, and then you test positive to rocuronium only, then you're an orphan rocuronium reactor. But if you react to rocuronium and vecuronium, then you're a polyreactor. And so let's just look. So these are two more patients that are polyreactors. And so you can just, over the years, you can collect lots of polyreactors in your clinic and document them. And so after a while, let's say you have 10 people that are polyreactors. They appear as though they would react to both vecuronium and rocuronium. Now, if 8 of them were referred to your clinic because they were given rocuronium, and only 2 of them were referred to your clinic because they were given vecuronium, that would suggest that the reason why, that would suggest to you that you're using 4 times as much rocuronium in the population over that period as you were vecuronium, because that would explain the discrepancy in the agents that were given to select these patients and get them into your clinic. So that's a way of determining the prescription rate of those particular drugs, at least the relative prescription rate. So we've done this in our clinic. I haven't published this yet, but it's written up and I just need to submit it. But we looked at our clinic data for 20 years, found 264 cases of anaphylaxis to either rocuronium or vecuronium, and 67 of these were polyreactors. Of the polyreactors, 54 were discovered by the administration of roc, and 13 were discovered by the administration of vecuronium. And so this would suggest that the prescription rate or administration rate in our community of rocuronium over that 20 years as an average, that rocuronium was 4.1 times that of vecuronium. And now we can use that to work out the relative risk based on the full number. But first of all, is this plausible? In 2011, the prescription rate for vecuronium was less than rocuronium, and rocuronium, the prescription rate was about 2.2 times that of vecuronium. But since then, 2011, the rate we're seeing of rocuronium anaphylaxis has gone up dramatically, and we think that's because the usage has gone up dramatically. And I did present on Tuesday a report from one of our 3 tertiary hospitals that felt that by 200, their survey they did in 2013, they were using 89% rocuronium as their muscle relaxant of choice. And worldwide, the rate of rocuronium usage is increasing and increasing. So this is the equation that I've developed for determining the relative risk of two reagents that have cross-reactivity. So R subscript O is the number of orphan reactors, and subscript P is the number of polyreactors. And so in this example, of the 166 people that were that had anaphylaxis to rocuronium, 112 of them were orphan reactors, and so you multiply the total amounts by the correction factor, which is found by the ratio of the polyreactors, and this gives us, in this example, a relative risk of rocuronium per administration compared to vecuronium of 1.9 times. And if we do if we just sample from the database multiple times to generate a measure of spread of the estimate, then we find that the 95% confidence interval, the lower limit is greater than 1, and so the p-value will be less than 0.05. Now, that's using bootstrapping. So now the beautiful thing about this is that you can go and hack anyone's paper that presents cross-sensitivity data, and you can get an estimate of the relative anaphylaxis rates. So I've done this to my own paper that we published in 2011 and found that the rate of vecuronium anaphylaxis compared to rocuronium using the data from the 2011 paper was 0.4 times. It was 0.4 times that of rocuronium. So again, that is about 2.2 times. Atracurium was half as likely as half the risk of rocuronium. I used Michelle Mertez's paper from 2011 that found that the risk of suxamethonium was 1.2 times that of rocuronium, and that sounds about right. We've always known that suxamethonium and rocuronium are the most risky drugs based on the population sensitization. And again, it gives you a atracurium rate of 0.5. We can use that using data from South Korea. We get vecuronium at 0.2 times the risk of rocuronium. And anyway, so you can, anyone that's got cross, and in fact, everyone in the audience can go home and look at their cross sensitivity data and get a relative risk from that, an estimate. Now, it may be that when you do this, that the estimate that you get doesn't match the non-prescription rates, and so that would be even more interesting, because we need to ask ourselves, what does cross-sensitivity mean? I think it's very rarely tested. The results of cross-sensitivity is very rarely validated by re-exposure to the drug or by provocation, and rightly so, and it's served us well so far. But what does it mean that when you have someone who's had rocuronium anaphylaxis and they test positive for rocuronium, what does it mean if the agents that they've never been exposed to have a positive skin test? And who knows, it may be that we're getting a lot of false positives to those other agents. But this technique will make that clear, because it will give you an incorrect ratio of polyreactors to orphan reactors relative to the non-prescription rates. If you can get prescription rates from a different method, i.e. ampule sales, or electronic records of prescriptions in theatre, and so that would be fascinating. And the other thing would be really interesting would be, does the polyreactor rate versus orphan reactor, does that ratio, is it different in different regions? In WA, it was 111 out of 166 orphans for ROC. 112 orphans for 166 polys for rocuronium in WA. Does it change over time? Does it change with Fulcodine exposure? And I mean, do the polyreactors, does that have a different pattern of specific IgE results? So, I mean, there's a lot of hypotheses you can generate and test once we have more data. The other thing I did with this was I looked at the relative risk over time epochs. So I binned all of the data into 4-year epochs. And it appears that the relative risk changes. And these are much smaller numbers, so there's going to be a lot more noise. But it doesn't look very noisy, this picture. So it looks like the risk was high, and then it became lower, and then it's steadily building up again. And this looks surprisingly similar to a paper published recently which looked at the gender inequality in perioperative hypersensitivity reactions, and in relation to Fulcodine withdrawal in the Scandinavian countries, or in Sweden in 2007, and so it just looks remarkably similar. So this is another potential use for this technique. Although I wasn't able to find any evidence that, certainly not, global sales didn't seem to go down, and there's no evidence from Western Australia about sales that I could gather over that time. Yes, so we can use it to hack lots of other papers, including this great paper by Brereton from the Royal Adelaide Hospital, which showed that dexamethasone was 1.8 times the risk of rocuronium, but we just need more numbers. And in fact, you can use this for any drug. It doesn't need to be just muscle relaxants. It can be any drug that has cross-sensitivity, has a population of patients that are polysensitive. In fact, I've shown that you can use it for opiates. For instance, if you were to have the side effect of, say, nausea and vomiting, and you were to test patients, obviously, in different presentations to different agents to see if they had nausea and vomiting, you could work out the relative risk of nausea and vomiting. But anyway, that might not be very useful. But in this case, this is useful. So this is a paper I've just hacked, which looked at the cross-reactivity between cisplatin and other platinum salts, so actually oxaliplatin and carboplatin. Now, they had more cases of oxaliplatin allergy than carboplatin, but because they presented their cross-sensitivity rates, I could determine that the market share of oxaliplatin was greater. And so therefore the risk of oxaliplatin compared to carboplatin is lower. So it's 0.8 times lower. So it's could be quite useful if it's validated. And there's a few assumptions. It assumes that that if you are polysensitive, that you would have had a reaction if exposed to the other drug. and it assumes skin testing is equally accurate. The last thing I'm going to talk about is pulse electrical activity and anaphylaxis, and we're preparing a paper at the moment on that, but I'm just going to focus on one part of this paper because we're running out of time. But one thing that became apparent after the UK NAP6 study that Sophie presented earlier is that that there is a significant incidence of neurocognitive complications after perioperative hypersensitivity, and in particular, I felt after PA arrest we should look at it. Now, there are existing scores for looking at neurocognitive dysfunction or complications after in-hospital arrest, but for example, this CPC scale. But I don't know if they're appropriate because the lowest score in this particular scale, beg your pardon, includes patients with mild cognitive dysfunction, and really, if you're turning up to an anaesthetic completely normal, you won't accept. You can't accept neurocognitive dysfunction afterwards as being your lowest outcome. So this is the modified scheme. So it's a five graded scale, and the first grade is normal because, as I've said, if you go into anaesthetic normal, you need to come out of it normal. The second grade is mild cognitive impairment, and this might be memory loss, anxiety, depression, sleep disturbance, difficulty concentrating. Essentially, you're still independent of your activities of daily living. Grade 3 is inability to cope with your activities of daily living. Grade 4 is coma. Grade 5 is death. So we'll focus on score number 2, mild cognitive impairment. And in fact, of the patients that had a PA arrest, it's about 60 cases so far. 14 of those cases, or 18%, had mild cognitive impairment, and this was at clinic review. It's unknown how long this persists for. In the NAP6 study, they found altered mood, memory, altered coordination, mobility, anxiety, but they did find that it was reported more commonly on referral, but by the time of clinic review, some of those cases at least had resolved, and so, but it still seems it would be interesting to find out, and until we start measuring it, we won't know. But how persistent these features are, and obviously if they're persistent, that's very, very significant. When we say anxiety, that's not anxiety regarding the surgery, say, or anxiety regarding subsequent anaesthesia. That's generalized anxiety, which is much more significant and could be more debilitating for the patients. So in terms of how you screen for neurocognitive dysfunction, it's important not to put ideas in patients' heads. And almost anyone, you can convince anyone that they're tired, I think, and you can convince anyone that that their memory's not as good as it was. But we need an objective measure, and for example, a good example or a good comparison is how we ask patients about intraoperative awareness, because if you go and ask someone after they've just had their heart surgery if they remember anything from during the operation, it almost does more harm than good in unnecessarily provoking anxiety. And of course the first response would be, why did you forget to turn the anaesthetic on, which may be true, but but there's no need to cause any harm if there is none. But you need to find out if they had intraoperative awareness. So the way we do this is we say to the patient generally something like, what was the last thing you remembered before you went to sleep? What was the first thing you remembered when you woke up? And that would give us, or give them, the opportunity to declare anything unexpected that happened during the operation. So we need a similar sort of thing for mild cognitive impairment. I don't want to introduce any ideas that weren't there already. The first question we ask is, after the incident, when did you feel completely normal again? Patients might just say, look, as soon as I woke up, I felt normal. And that just ends it. That's very efficient at excluding this. Has there been any change in your living arrangements? Now, this obviously is looking at a grade 3 answer. grade 3, a loss of independence. The third question would be to ask them, have you been able to do all the things you previously could do? And obviously for both the second and third question, you have to exclude surgical causes for any reason why you're not independent anymore or you can't do things that you used to do. But it does give them an opportunity to talk about the fact that they just can't concentrate anymore, or they just don't have any energy, or they can't sleep, or whatever. Now, the next two questions, it's very important. There's some subtleties to them that, we've developed this score intentionally so that that it's looking back, and it's not we can't suggest things that would change their responses. So we say to them, has anyone commented to you that your behaviour is different since the incident? And notice that we're asking them if someone has previously commented to them, which they either have commented to them or they haven't commented to them. And it can't be changed by the fact that I'm asking this question. And then the next one is, we ask them, have you commented to anyone previously that you've noticed a change in the quality of your sleep, which is the most common reported problem? Memory, and I think memory, the thalamus must be very sensitive to hyperperfusion or hypoxemia, because it's very common that they have short-term memory loss. Like they lose a couple of days afterwards. Concentration, they might be overwhelmed making decisions, or mood. And again, as I've said, this is non-specific anxiety. It's not specific anxiety about the fact that, they've got this unknown trigger for anaphylaxis and they have to have another operation or something like that. It's just generalized anxiety, irritability, depression, which is new since the reaction. And I think this is the line of questioning that we're proposing. And it would be, and then if you score the answers on the basis of that scale that we've modified from a CPC scale, I think we should generate some data and we can investigate this phenomenon further. Thanks very much for your attention.